Welcome everybody to today's webinar for the Child and Adolescent Psychiatry Portal. Today's talk is on ADHD, something we see all the time. Pearls about presentation, identification, and support. I am pleased to introduce our two speakers for today. Dr. Lauren Schumacher is a child and adolescent psychiatrist for the Division of Mental Health and Child Development here at UCSF Benioff Children's Hospital in Oakland, and also in the Division of Child and Adolescent Psychiatry in the UCSF Department of Psychiatry and Behavioral Sciences. She provides clinical care in the outpatient clinics at UCSF Langley Porter Psychiatric Hospital and clinics in San Francisco, as well as at UCSF Benioff Children's Hospital, Oakland. She also consults for our CAP phone line, so some of you who may have had a chance to speak with her already. She has particular interest in anxiety, attention deficit hyperactivity disorder, and medical education, and has co-authored a chapter on the pharmacological treatment of ADHD for an upcoming textbook on pediatric psychopharmacology. We also have Dr. Lauren Hack, who's an associate professor and attending psychologist with research and clinical interests focused on cultural influences to mental health conceptualization, assessment, and treatment, and also on accessible and culturally appropriate evidence-based services for traditionally underserved youth and families worldwide. When she's not conducting clinical research or teaching, she splits her clinical time between the UCSF Hyperactivity Attention and Learning Problems Clinic or HELP Clinic, as well as the Wavefront Cognitive Behavioral Therapy CBT clinics, as well as the Child and Adolescent Psychiatry Portal, also providing our what we used to call second step services directly interfacing with families. So with that, I'll pass this on to Drs. Lauren and Schumacher and
Thank you all so much for having us today. We don't have any conflicts of interest to disclose. And our presentation today is really focused on these three main areas. The first, we're going to talk about the presentation of ADHD. Next, we're going to talk about how do we identify ADHD in youth. And then lastly, we'll move on to how we can support youth with ADHD using medication and behavioral services. To start us off, I want to ask something called a wait question. So for those of us in the webinar, I'd like you to type your thoughts in the chat, but don't hit send until we say go. Those of you listening on video, just reflect on your answers to this question. So what is ADHD? When you hear ADHD, what does that bring up for you? So again, those of us on the webinar, go ahead and start typing your thoughts into the chat. And hit send. Great. So we're seeing, thank you, those of you who are putting your thoughts into the chat. And you'll see actually a lot of overlap with what you all are identifying in the presentation that we're going to talk about. So here is the diagnostic criteria for ADHD according to the most updated Diagnostic and Statistical Manual. So in order for a child to meet diagnostic criteria, they need to have at least six inattentive symptoms and or hyperactive impulsive symptoms. And we need to see that those are consistent across settings. So often for youth, we're talking about at home and at school. And we want to see those consistently for over time, not because of another disorder. We used to call ADHD subtypes. We now call them presentations because research shows us that this can really change over time. There we go. Sorry about that. The slide, I've hit pause share and then didn't hit resume. So here's again a look at those inattentive and hyperactive impulsive symptoms, as well as the other criteria, which sometimes go overlooked. So what's really important actually is not just the presence of symptoms, but also that we see these symptoms impair the youth's functioning in different settings. So again, oftentimes that's at home, at school, and with their peers. So let's take a closer look at how ADHD symptoms tend to impair children's functioning. Sometimes we think about this as their life worth living, what's getting in the way of them reaching their success and potential. So oftentimes kids are first identified as having ADHD when they begin school and start to demonstrate difficulties that interfere with their learning and sometimes the learning environment of others. So for example, these children often exhibit more negative off-task classroom behaviors, such as interrupting or leaving their seat. And we also see less positive classroom behaviors like academic engagement and focusing. In addition, we see that youth with ADHD often experience more negative relationships with their classmates, their parents, and their teachers. So this can be seen with non-compliance to instructions, sometimes verbal or physical aggression. And really, we see that this is often due to a difficulty regulating their emotions. So kids with ADHD, their brains actually are sort of wired to over-perceive negative feedback and under-perceive positive feedback, which can just exacerbate these relationship difficulties and a hard time regulating emotions. We can see that these impairments often blend over into the home and family environment, such that kids are having more negative interactions with their parents as well as their siblings. They have a harder time following routines and tasks. And we also see a higher association with parents of kids with ADHD also having their own difficulties with mental health or substance use disorders, as well as their marital relationships. So if we look into the neuroscience world as to what about the brain is causing these core deficits and these impairments, we see two areas that really are implicated. The first is executive functioning. So we see that these kids have difficulty with visual, spatial, and verbal working memory, inhibitory control, vigilance, and planning. So they're going to need more help or more scaffolding, breaking things down into steps, knowing how to get started, for example. When we look at motivational pathways, or what is motivating versus overwhelming, we see that kids with ADHD overestimate the relative size of immediate versus delayed rewards. And we also see that they respond stronger to immediate and tangible rewards compared to abstract or delayed gratification. Here are some other domains that we see impaired in the brain, including temporal information processing and timing, speech and language, memory span, processing speed, and response time. We also see difficulties with arousal and activation, as well as motor control. And yes, I'm fine if these slides are shared after. So I oftentimes get asked from parents, from teachers, from people in the community, kind of, is ADHD really just a white upper middle class American disorder that has come out of the school environment that we force children to be in? And actually what we see if we do really good culturally sensitive research is the worldwide prevalence of ADHD hangs around 5 to 15%. So we call this an equal opportunity condition. It really can impact anyone. However, what we do see is that the rates of ADHD in terms of how often it's identified, diagnosed, and treated can really differ across geographic regions and ethnic racial background. And this in part is due to cross-cultural differences in what we think is acceptable versus unacceptable behavior across contexts. We also see some of these differences aligning with access barriers or structural health inequities related to our healthcare system.
So there was a large study that looked at commercially insured children, which found that overall there were the highest rates of diagnosis of ADHD in white children, with lower rates in Black and Hispanic children and lowest in Asian children. And kind of based on review, it looked like this was kind of a result of underdiagnosis of minoritized children rather than an overdiagnosis of white children. They've also found that teachers are more likely to rate non-Latinx Black children higher on inattentive and disruptive behaviors than white children. And they've also seen, kind of in terms of that access issue, that white and Asian children are more likely than Black or Latinx children to have access to comprehensive neuropsychiatric evaluations when ADHD is diagnosed. Another factor that kind of complicates diagnosis and recognition of ADHD is kind of co-occurring and differential disorders. It's estimated that about 66% of those with ADHD have a comorbid psychiatric condition. So really, comorbidity is the rule rather than the exception. And here we've got a number of different things that both can be kind of in the differential diagnosis, can potentially be mistaken for ADHD. Things like trauma, sleep disorders, anxiety, depression can all cause the problems with attention that are, really unrelated potentially to ADHD. And they're also frequently seen in kids with ADHD. So it can be a challenge to sort out. Kind of in the boxes here, we have some different rating scales and questionnaires that can be helpful in kind of further evaluating for some of these potential comorbid conditions. And I think also keeping in mind, considering a CAP call or referral if needed for kind of assessment or management of comorbidities.
So let's take a little bit of a deeper dive at a look at a common co-occurring disorder question. And this is the overlap or potential uniqueness of ADHD and PTSD. So we do see some pretty substantial overlap with behaviors that could be attributed to ADHD or to PTSD, right? So difficulty with concentration, memory, restlessness, risky behaviors. But then you can also see here there are some distinct behaviors or symptoms as well. And again, as Dr. Schumacher said, sometimes a child could have both, sometimes a child could have one condition, which is sort of presenting as if it might be the other condition. This graphic comes from a piece that one of my previous interns actually wrote for CHAD. So I'd encourage you to take a look at that piece because she kind of goes through seeing a child present to the clinic and kind of what questions can you ask to try and figure out if this is ADHD, PTSD, or potentially both. One thing that's really important to know is that ADHD is not typically outgrown. We sort of used to think that decades ago, but now longitudinal research is really showing that even if the majority of kids with ADHD might not meet the full set of criteria for ADHD, as adults, we often see some persistence of symptoms as well as impairment. We used to talk about the course of ADHD as a phenomenon of thirds. So this is a sort of simplistic look where we thought about a third of kids tend to really learn how to compensate with their difficulties and lead very successful, thriving lives. About a third continue to struggle, and then a third might have more severe problems like substance use, conduct disorder, other more severe problems. But really recent research is actually showing that most people with ADHD have these fluctuating periods of remission and recurrence over time. So at any given point, an individual who had ADHD as a child may feel more or less impact of that condition across their lives. This is another look from a 2015 review in Nature at how ADHD tends to impact people across the developmental spectrum of lifetime. And really what we see is that genetic risk factors as well as psychosocial influences from our environment explain why ADHD can look so different across different people or even within the same person throughout their lives. So time for our next weight question. So we'd like you all to let us know, how do you identify ADHD in your practice? Do you have any favorite tools? So go ahead and type thoughts in the chat. Wait for a moment to hit send. Some people are already sending, that's fine too. Okay, and go ahead and hit send. Wow, we have got some consistency of some favorite tools. here's a look at some really recent guidelines from the American Academy of Pediatrics. And the first three are really looking at identifying ADHD. So you can see they recommend evaluating for the condition in 4 to 18-year-olds, looking at if those DSM criteria are met. And really to do that, because we need to see symptoms and impairment across settings, we really should be obtaining collateral information from parents as well as someone in another setting, oftentimes teachers or therapists or coaches sometimes. And then we also want to assess for co-occurring disorders. So unfortunately, ADHD is not like diabetes. We can't take a blood test and definitively say if someone has it. So what we want to do ideally is gather information using multiple methods across settings, using different kind of contexts. And again, really important to ask about functional problems as well as symptoms. However, as we know, this might not be completely realistic in your different settings. One tool that we have is using telehealth. So using phone calls or video calls or sending electronic rating scales. This has been a really nice advancement that we've had in the recent years, especially getting teacher information. A teacher is likely not going to be able to come into your clinic, but they might be able to have a brief phone call with you or fill out some electronic rating scales. And oftentimes getting a release of information to speak to the school is how you can get permission to get that information from teachers.
So some of the most commonly used scales in primary care include the Vanderbilt, which has a parent and teacher version, the SNAP, which also has parent and teacher versions, and also the adult ADHD self-report scale for self-report for 13 and up. I think from our informal poll here, it seems like the Vanderbilt is by far the most popular, and that's also my favorite. I particularly like the Vanderbilt has both an initial and a follow-up version, and the initial, in addition to having the 18 ADHD symptoms, also screens for oppositional defiant disorder, conduct symptoms, as well as some anxiety and mood internalizing symptoms. And then both the initial and follow-up also ask about functional impairment questions, so it can be very helpful to use. Kind of think about using rating scales both with the start of the assessment to both help with diagnosis as well as provide a baseline. And then to check in, do repeat rating scales about every 6 months during treatment after there's been changes in medication to see if there are further improvements in symptoms with that medication change. And if there's, reported significant changes in affect behaviors or side effects to help give you a baseline before switching or making changes.
Okay, so our last weight question for the day, what sort of treatments, resources, or referrals do you tend to use in your practice? So go ahead and type your answers in the chat. Wait just for a moment to hit send. And hit send. Great, so we're seeing parent training, meds, stimulant meds, counseling, parent training meds, behavior therapy meds. Great, so a lot of overlap. Attitude ADHD magazine, awesome. School supports, great. Behavioral and developmental pediatricians, not enough Spanish speaking interventions. That is certainly a gap that actually is near and dear to my heart. IEP 504, great. So we're going to talk about most of these actually. So if you see the guidelines continued, really 4 through 8 are looking at these treatment and other social supports that we recommend. Right, so because ADHD is really a chronic health condition, psychoeducation is really important for everyone. We recommend behavior therapy and school accommodations or interventions as first line for 4 to 5-year-olds, and then using along with medications for 6 to 18-year-olds, and then pharmacotherapy as well when indicated. So I love the comment about not enough interventions in Spanish, and absolutely that is something that my team personally works on, but we need more work on. We do have some resources here that we've collected for you that are available in English and Spanish. And so you can see we have some from CHAD, from Child Mind, from the CDC, from our CAP website. Did I cut out for a second? But I'm back.
You're fine.
Okay, great. And also I love the recommendation for Attention Magazine. And I see we have a request for Chinese resources too. We can absolutely add that to our to-do list. Thank you for that. So here's a closer look at some other recommendations for resources. We've got some book recommendations, medication guides, as well as it seems like we're on the same page that Adhd magazine can be really helpful. Okay, let's take a look at behavioral and education interventions. So the reason that these are so consistently recommended across the board is because kids are oftentimes having difficulties with their impairment that may persist even if they're on a good medication regimen. And across the board, whether we're working with parents and families or whether we're working with teachers in the school setting, really across the board, because of those brain difficulties we talked about at the beginning of the webinar, we want these supports to have clear, consistent, realistic expectations. So oftentimes we're breaking kind of larger tasks down into really small steps. We want to be giving really frequent positive feedback for when children are making those steps in the right direction, which will increase the positivity and interactions between these kids with ADHD and those in their environment. We have some resources here for kind of handouts and tips for some of these strategies that can be put into place at home and at school. Let's take a closer look at behavioral parent training or family interventions. Again, because ADHD is really a chronic condition and has functional impairment as well as often co-occurring difficulties, behavioral parent training teaches families lifelong skills for how they can take control, provide that structure and that scaffolding, a lot of praise for meeting those expectations, which in turn improves the relationships. These can be delivered with individual therapy, group therapy, and we even have some evidence that self-guided online behavioral parent training can be helpful. And sometimes these can be delivered in schools if school clinicians like school social workers have been trained. Here's a look at some goals that can be targeted in behavioral parent training, right? So we're trying to increase compliance and acceptance, independence, completion of tasks, and respectful relationships. And we also are really helping the parents and the caregivers, right? It can be really difficult to be a parent or a caregiver of a child with ADHD. And so we're also kind of helping them have more positivity, more warmth, and more consistency. We also can focus on parent stress, how to scaffold some of these skills that are hard for kids with ADHD. And then as kids get older, we can actually also incorporate direct training with them. Here's some resources I know people are asking about how we actually get families these treatments, and it can be challenging to find providers who are covered by insurance, but we do have some kind of self-help resources that you can give families in the meantime. And we also recommend, reaching out to our CAP line for care coordination or even a ROC family consult. When we're looking at school intervention, the rationale is that these deficits with executive functioning and motivation can remain even if kids are on medication, and they can really impair children as well as other children in the classroom setting. So we're looking at trying to increase how engaged they are in the academics, how well they are kind of following rules and engaging with others, which in turn can indirectly improve their academic performance. So different strategies that classroom teachers can put into place. Proactive strategies are providing and reminding cues ahead of time, which makes the child more likely to follow those expectations. Redirection and using labeled praise. And then we have a lot of evidence for token economies or systems where children sort of earn points or stickers or tokens for following the rules every day that they can then exchange for larger rewards or privileges. Children with ADHD can qualify for extra accommodations or supports in schools because of the IDEA Act. So they either could qualify for an IEP under the other health impairment or potentially one of the other categories with one of their comorbid disorders. For example, if they have a comorbid emotional disturbance or learning disorder. Oftentimes, though, kids are going to receive accommodations under a 504 plan, and you can see some examples of accommodations that kids tend to benefit from. On our CAP website, we have more information about what is an IEP versus 504 plan, and we also have a request letter that you can actually provide families so that they can turn that into the school to request an evaluation. At this point, I am going to stop the share and pass the mic over to Dr. Schumacher to talk more about medication.
Actually, do you mind continuing to share?
No problem.
Thank you. So for kind of the next piece of treatment, if you remember back to the AAP clinical practice guidelines for ADHD, for the 6 and older, another first-line treatment includes FDA-approved medications for ADHD. And for those under 6, methylphenidate is a second-line option. So the kind of medications that are included in this FDA-approved group include the methylphenidate stimulants, the amphetamine stimulants, the alpha-2 agonists, which include guanfacine and clonidine. Alpha-2 agonists in combination with stimulants are also specifically FDA-approved. And then the norepinephrine reuptake inhibitors, which includes atomoxetine, as well as the relatively recently approved viloxazine. So some different things to think about with when you're thinking about starting medication. You want to think about kind of for whose benefit we're thinking about starting the medication, and kind of want to keep the patient and their kind of functioning and well-being centered in our mind. It's helpful to think about kind of what duration and type of medication would be most useful for them. If it's a younger kid with a shorter school day, might be a shorter acting stimulant will be enough. If it's a high schooler who's got a long school day plus activities plus a couple hours of homework, really thinking about a long acting medication. Also helpful to think about kind of sequencing with non-pharmacological treatments, kind of also trying to get behavioral interventions and strategies, school accommodations on board in addition to medications. Thinking about insurance coverage, which medications are preferred by the insurance, and then also kind of how the caregivers feel about medication. Some are very supportive, some are pretty hesitant, and really important to meet people where they're at. There's also potentially concerns both for diversion or abuse, kind of with either patients or family members. So that's something to keep in mind. And then keeping in mind adverse side effects, which we'll go into more detail with this particular medications. So with stimulants, these are our first-line medication treatment, and that's largely because they've large body of research attesting to their efficacy as well as their overall safety. They're very effective with an effect size of around 1. And a response rate of over 70% to a trial of one stimulant, which increases to over 80% with the trial of a second stimulant in those who don't respond to a first. So they're very effective at improving ADHD symptoms. That being said, they do tend to have some side effects. Most commonly, we see things like decreased appetite, sometimes weight loss, stomachache, headache, sleep disturbance. I'm sure kind of all of you guys have probably experienced these in your patients. Less commonly, we'll sometimes see behavioral rebound, hypertension or tachycardia, sweating, tremors, and very rarely there might be people who experience hallucinations or psychosis. That tends to be primarily at super therapeutic doses of stimulants. Some may also report peripheral vasculopathy, priapism, emotional blunting, or compulsive skin picking. Some things that can help with common side effects are with decreased appetite. It tends to hit mostly at lunchtime, afternoon time when the medication is fully on board. So really encouraging substantial protein-rich breakfast and then maybe afternoon snack as it's wearing off and dinner to help compensate for eating less at lunchtime. There's also a study that looked at in those where there were particular growth concerns, having drug holidays on weekends and or the summer, and considering calorie supplementation can both be helpful. If they're reporting stomach aches, making sure they eat before taking it. And then if they're reporting sleep disturbance, first checking on when they're taking the dose. I sometimes have teenagers who are reporting difficulty sleeping, and it turns out they're sleeping in and taking their long-acting stimulant at like 12 or 1 p.m. So first find out when they're taking it, encourage them to take the medication earlier in the day. You can also think about switching to a shorter acting medication. So if they're on a long-acting one, can shift that's like more like 12 hours, can shift to a medium acting one that lasts more like 8 hours, or potentially even to a shorter acting one, short acting that would last about 4 to 6 hours. It can also be helpful, of course, checking in on sleep hygiene, can consider adding melatonin, and could consider either switching or adding an alpha-2 agonist or switching to atomoxetine. And then if there's issues with rebound, where kind of the ADHD symptoms come back worse than ever in the evening, afternoon as the meds are wearing off, considering switching to a longer acting stimulant medication be helpful, or adding an afternoon booster dose can kind of help smooth that the decrease of the medication. Next slide. And in thinking about choosing a stimulant, there's a lot of different choices, which often can be kind of overwhelming. But one place I really start with is the mode of administration. So you always want to find out, especially in the younger kids, if they're able to swallow pills. If they can, then there's kind of all the options. If not, there are a lot of options that don't require them to swallow pills. So there's many of the capsules can be opened and sprinkled in a small amount of applesauce. There are also chewable, liquid, and patch formulations as well. It's all, again, helpful to think about the duration of action, how long they're kind of needing the effect of the medication to last. At this point, there really isn't good evidence that pharmacogenetic testing is helpful for determining which medication to choose. And one resource I especially recommend is the Adhdmedicationguide.com. It's a chart that has pictures of all the different ADHD medications, and is, I think, both helpful for clinicians to look at, and also can be helpful for kids and families to kind of see what the medication looks like as well. Next slide. In terms of monitoring, before starting these medications, especially stimulants, you want to screen for any personal or family history of heart problems, especially syncope, arrhythmias, murmurs, sudden cardiac death. You also want to screen for potential contraindications, such as the substance use disorder, eating disorder, seizure disorder, mania, or psychosis. These kind of, if you do find these present, they're not absolute contraindications, but you'd want to have them get treatment and stabilize these conditions first before you think about starting a stimulant for ADHD. At baseline, you want to get blood pressure, heart rate, weight, and height, as well as we talked about before, getting baseline ADHD symptom rating scales from parents and teachers, and also the adolescent themselves for 13 and older. Interestingly, studies have found that more frequent visits are associated with more effective medication treatment for ADHD. So kind of when you're first starting it, if possible, trying to do follow-up visits weekly or every other week. These can also kind of take the form of, telehealth visits, of course, or even kind of MyChart or phone check-ins. And then follow up monthly as they're kind of still adjusting the dose. And then once they've been stable, can spread that out to every 2 or 3 months. At each visit, you want to kind of monitor the ADHD symptoms as well as for side effects. You also want to ask about the dose they're taking, the schedule they're taking the medication, and if they're missing any doses. With these, since they're not one you have to take consistently every day, I always check on kind of when they're actually taking it, because that can vary a lot depending on the kid and family. And it's important to know if they're complaining of issues that you thought the medication was helping with, you want to first make sure they're actually taking the medication when those issues are happening. You also want to kind of ongoingly check blood pressure and heart rate, ideally every 3 months, and then height and weight at least every 6 months, and then trying to get teacher input at least once a semester. And then think about repeat rating scales after you've make a dose adjustment to see if you see additional benefit. Next slide. Next up, we have the alpha-2 adrenergic agonists. So this is guanfacine and clonidine. They're also effective for treating ADHD, but have a smaller effect size than stimulants. So while stimulants have an effect size of around 1, the alpha-2 agonists, it's around 0.6. With these ones, I think important thing to always make sure families realize is, unlike the stimulants, which you can take some days and not take others, and they'll still be helpful on the days you take it, this is a medication that it's important for them to take consistently to see benefit. In terms of side effects, the most common side effects are somnolence, fatigue, and sedation. So they can make you tired. Less commonly, we might see headache, hypotension, dizziness, and there's very rare reports of hallucinations with guanfacine. An important side effect that they don't have is you don't see significant changes in body weight with the alpha agonists. So this is a good option to think about if there's kind of either baseline concerns about a kid with kind of poor eating, underweight, failure to thrive. And it's also a good option to consider if in a kid that's tried a couple stimulants and had issues with the appetite suppression side effects. Next. In terms of helping manage the side effects with the tiredness, it's helpful to at least start by having them take it at bedtime, because then if it does make them tired, shouldn't affect them as much. Clinically, guanfacine tends to be less sedating than clonidine, so I tend to start with guanfacine. And then with some kids, it doesn't make them tired, or kind of as they get used to it, they're not noticing that. So sometimes if they're really not noticing it making them tired and there's kind of partial benefit, then I'll ultimately have them switch to taking it in the morning time. So I always have them start in the evening. If they're noticing some hypotension or dizziness, making sure they're drinking lots of water, staying adequately hydrated, encouraging them to get up a little bit more slowly if they've been lying down for a while, checking in on blood pressure. And generally, this tends to get better within a week of them starting the medication or of a dose increase. So if it's persisting longer than that, though, or really problematic for them, then considering lowering the dose or switching to other medications. And if they're reporting nausea with it, make sure they're eating something before taking it. All right, next slide. And then in terms of atomoxetine, this one's similar to the alpha agonist. The effect size is around 0.6. So still can significantly improve ADHD symptoms, but smaller effect size than the stimulants. It's also one that needs to be taken consistently every day to have benefit. This one, some of the most common side effects are weight loss, GI symptoms, decreased appetite. We can also see headache, dizziness, fatigue. Interestingly, we don't see insomnia with this one. So this can be a good option in those kids that are having issues with sleep on stimulants. Some rare side effects that to consider with atomoxetine are disturbances in sexual function, priapism. There is a black box warning for increased SI. And then also liver toxicity has been very rarely reported as well. In terms of the kind of more common side effects, generally the dosing guidelines is to start at a lower dose and kind of go up after a week. So doing that, as well as starting with the dose split BID, can both help minimize side effects. So you start at that lower dose, split BID, then increase it, staying at the split dosing. And then once they're doing okay with that, you can consolidate to once a day dosing for kind of easier administration. A 2014 meta-analysis looked at this kind of concern, black box warning, concern for possible risk of SI, and didn't see any increased risk for suicidal behavior. So it's something we warn families about, but is kind of a very rare thing that overall, really the benefits of treating ADHD seem to outweigh that rare risk. And then kind of this last algorithm kind of gives a big picture view of how we think about a lot of this. So kind of with all our kiddos, but especially our kiddos with ADHD, we want to be thinking about how they're spending their time. Are they engaged in healthy activities, nutrition, sleep, and encouraging all those wellness behaviors. Then for the all kids thinking about with ADHD, thinking about behavior therapy, school accommodations as first line options. And then with the older 6, then also thinking about the medication as first line options as well. Among the medications, stimulants are our first line choice because of their large effect size. Once you start the stimulant, you want to optimize the dose, looking to really maximize benefit while minimizing side effects. Either if there's issues with significant side effects or only a partial or no response to an optimized dose, then think about switching to a stimulant in the other class. So if you start with methylphenidate, then switching to something in the amphetamine group. Again, optimizing that. If there's issues with side effects or no or partial response, at that point, you could think about adding an alpha-2 agonist or potentially switching to an alpha-2 agonist or a norepinephrine reuptake inhibitor. I think at this point too, it's always good to be, if you're not seeing the treatment responses you're expecting, to again be checking in on your differential diagnosis. Are there other things? Is there something like sleep apnea going on that may be causing attention problems that these treatments are not addressing? You can also switch if there's issues with one or the other of alpha-2 agonists or the NRIs, switch to the other one, and then at that point could think about off-label medications such as bupropion. And then additionally on the side here, we've got sleep problems because sleep problems are so common in kids with ADHD, even those not on any medications. So also checking in on sleep, making sure to reinforce good sleep hygiene, and can think about potentially adding a melatonin or potentially an alpha-2 agonist if needed. So then we just bring back the AAP guidelines, just kind of summarize overall. So you want to think about, for 4 to 18-year-olds who are presenting with issues with school or concerns about attention hyperactivity, evaluating for ADHD. You want to ensure DSM-5 criteria is met, including collateral from multiple informants at multiple sites, such as parents, teachers, therapists. You want to assess for co-occurring and differential physical and mental health conditions that might be either mimicking ADHD symptoms or kind of co-occurring with them. You want to take a chronic health condition approach to treating ADHD. And then for the preschool age, really focusing first on those behavioral therapies, home and educational interventions, second line methylphenidate, and for those 6 and older, kind of the behavioral interventions at home and school, and then also considering FDA-approved ADHD medications. You want to try to titrate those doses to maximize benefit while kind of keeping side effects tolerable. And then if experienced in diagnosing comorbid conditions, can also initiate treatment of such conditions or make appropriate referrals. All right, and then.
Wonderful. Thank you so much for this incredibly informative talk. We have a ton of questions here. I'm going to try to organize them a little bit, but I'm going to go ahead and flash up our QR code so you can start checking yourself in, and this is how you get credit. So there's the QR code, put your smartphone up to it, and you should be able to follow the QR code to check in. I'm also going to go ahead and put into our chat right now. This is our this is a hyperlink if you're already on your phone that you can follow this hyperlink to check yourself in. So there are a number of questions about diagnosis and the rating scales. And so there was a question about to what degree do you actually need a subspecialist, like a DD pediatrician or a neuropsychologist involved in making the diagnosis? And one person pointed out the fact that sometimes the Vanderbilts will look not positive, right? But then a neuropsychologist will later come back and make the diagnosis. And this can be a little bit confusing. So I want you to speak to, making a diagnosis just as a PCP without specialty involvement, and your thoughts.
Maybe do you want to start, Lauren, and I can follow up?
Yeah, so I think it's helpful to keep in mind that ADHD is a clinical diagnosis. It's not one that we don't require kind of special testing, psychoeducational or neuropsych testing to diagnose it. So I think it is definitely something that can be diagnosed in primary care. I think often how I think about it is that with kind of more straightforward ADHD, I think kind of going ahead and diagnosing in primary care makes sense. If there's a lot of kind of comorbid concerns, like there are also concerns about anxiety and mood as well, or trauma, that those are cases that I think it's especially helpful to think about referral to kind of to developmental peds or child psychiatry. And then in particular, if there's also concerns about learning disorders, is when it's especially helpful to get that neuropsych or psychoeducational testing.
Okay. Wonderful. There was a question about newer forms of the Vanderbilts versus like older forms of the Vanderbilts, and the initial versus the follow-up form, when you would use each.
So I would say with the kind of the initial versus the follow-up, I tend to use the initial when I'm kind of first making the diagnosis, or if a patient has maybe a history of it, but they're new to me, just because I appreciate getting that additional, it provides that additional information about, are there also oppositional symptoms? Are there some internalizing symptoms? And then often kind of like if there's some positive symptoms in that more of those last questions about anxiety and depression, then I would follow that up with some additional anxiety and depression screening. So things like the PHQ-9 or potentially the SCARED. And then I like the follow-up one. The main advantage is shorter. It's got the 18 ADHD symptom questions. It has some questions about potential side effects you might see on stimulants, and then the functional impairment one. So I like using that kind of once I've started medications, or if we're kind of doing just it's been a while since we've had the forum and want to check in and see maybe they're in a new school year, see how they're doing with a new teacher, then I use the follow-up one. And the main advantage is just to try to at least decrease kind of survey fatigue from the parents and teachers.
Which is real. And you mentioned the SCARED, and I'm not sure if everybody here is familiar with the SCARED, because there was a question about anxiety screening, especially given the new U.S. Preventive Services Task Force recommendations on anxiety screening from ages 8 and up. What do you recommend to use?
Yeah, so the SCARED is an anxiety questionnaire. It has both parent and child versions. So I really like that because you can get both the parent's perspective as well as the child. And it then breaks down the symptoms into different types of anxiety. So you might like, is it more social anxiety, generalized anxiety, more panic symptoms, different things like that. The SCARED is available on the CAP website. If you go under anxiety screeners, you can see it there. For a little bit older kids, I also like the GAD-7. The main advantage of that is it's much shorter than the SCARED, but that one, there isn't a parent report version. So that one's just a self-report.
Fantastic. So I think that those are most of the screening questions. There were some comments also on like doing like ACEs screening when ADHD concerns come up. Is this something that you guys think about very often? And how do you screen for those comorbidities? I would love to hear, or like possible differential. What would be your kind of go-to approach when you're first thinking about ADHD diagnosis?
I mean, I'll say generally a really helpful question is thinking about the sequencing and the timing of when problems are being recognized. So if in either conversation with parents or teachers or in rating scales, you're seeing that symptoms of trauma or trauma reactions or depression or anxiety are happening, and ADHD symptoms are really happening only after we're seeing those untreated symptoms, that gets me wondering about if those trauma, anxiety, depression presentations might actually be core. And if those are treated, kind of seeing, are you still seeing those difficulties with inattention and hyperactivity, impulsivity, or the vice versa? We can also see that untreated ADHD can leave children feeling very down, upset, anxious. And so a general question is, what are the sequencing of when things presented? And if you get treatment or supports for different things, are you seeing some other symptoms clear up?
Okay, wonderful. So looking at the sequence, the order in which things come in, historically when we get that. Okay, as we move, there's a bunch of questions about comorbidities, right? With ADHD and ASD, ADHD, and anxiety. Like when you're seeing signs of anxiety and mood disorder also coexisting with ADHD. Is this something that a PCP should try to tackle, or is this something that a PCP should refer? Like, what are your thoughts on starting to like treat comorbidities along with ADHD?
It's a tough question, and I think it can definitely be challenging to sort out. I think when you are seeing kind of a lot of, when it's a more complex picture, I do think probably the ideal is referral for kind of more in-depth evaluation. And also the reality is we know that often that's really hard to do. So I think it is helpful in the meantime. I think it can be helpful to get those Vanderbilts, but also get that scared to look for anxiety, get that PHQ-9 to look for depression, kind of think about pearls for screening more for trauma. And then I think, as Dr. Hawk was saying, kind of think about the timeline, trying to clarify with families which of these was first, which of these came later. And then also I think a piece that helps orient me is one, like you can't tackle everything at once. So you end up having to kind of take things one at a time, and that our understanding will evolve over time. So often what I'll do is try to really drill down with the parents and the kid. Okay, what's the most problematic piece right now? Is it the attention? Is it the anxiety? Is it the mood? And then really focus on targeting that first. And then as that piece is improving, seeing what else is left. So if it's really more anxiety, like they're like, oh, she's so anxious, when before tests, she has panic attacks. So maybe think about first either CBT for that or SSRI for the anxiety piece. And then looking as the anxiety is addressed, does the attention piece get better or does that persist? So that can be helpful. And that sometimes we can't fully sort it out at a snapshot in time. And it really ends up being kind of over time observation that helps us understand what's going on.
Yes.
I'll add that our behavioral treatments and our cognitive behavioral treatments for ADHD, anxiety, depression, trauma in young children, a lot of the strategies are the same, right? It's teaching parents and teachers of these kids to set very clear, predictable expectations, use a lot of praise for them, using calm down strategies and social interaction strategies. And so if you're concerned about this kid's functioning and you can get them in for some CBT or the family in for some behavioral therapy, it's oftentimes going to help regardless of what the starting point was.
Absolutely. And I would say also for like specific questions, do call CAP. This is what CAP is for. So call and you can talk over the specifics of your particular case. There are a number of questions also on like medication, like when you're starting medication. One question, when do you get that EKG? Can you like speak to that?
Yeah, so I would say, as kind of the current recommendations are that you don't need a routine EKG for screening purposes before starting a stimulant. So when it tends to come up is one, if the kid has any concerning cardiac history, if you encounter anything concerning in terms of their cardiac exam, if they're having episodes of syncope, things like that, those would all be flags to do that before starting a stimulant. And then I think particularly if there's a family history of kind of early cardiac death or arrhythmias in particular, that those would be other places to think about doing the EKG. I feel like often when I start screening for that, I get the stories of, grandparents who had heart attacks in their 60s, 70s, that really that wouldn't be kind of enough to trigger EKG, but more like kind of if there's a family history of kind of younger cardiac concerns or arrhythmias.
Okay, fantastic. There's a question of what's the latest research on the effects of stimulants and height velocity?
Yeah, so there's from the MTA study, which has now been following kids treated with behavioral and stimulant medications from when they were kind of around 12 to now into their 20s. There does seem to be some kind of global effects. I think one thing to keep in mind is these are, at this point, it's naturalistic follow-up, so it's not randomized control. So these are correlations. We can't really determine causation, but they grouped the kids into people who over time had kind of pretty significant stimulant treatment overdoses over time, those who had kind of a negligible amount, and those who had a medium amount. And they did see that on average, those who'd kind of had a higher lifetime dose of treatment with stimulants were on average kind of a couple centimeters shorter than those who had negligible treatment with stimulants.
Okay. There are some other questions about like medication side effects, like stimulants possibly worsening anxiety. And when would you consider treating anxiety first before even trying a stimulant if you're considering anxiety?
Yeah, so overall, the data is that stimulants don't worsen anxiety, and in some cases can actually even improve anxiety. And I think this is especially true for, if you think about like ADHD can be a very anxiety provoking experience, that you're having trouble paying attention, you space out, and then suddenly, the teacher is calling on you and you have no idea what's going on. That's very anxiety provoking. So generally, if they have both ADHD and anxiety, the anxiety is not a reason not to treat with a stimulant. That being said, we do tend to see kind of small increases in heart rate with stimulants that are generally not clinically concerning. But I think especially for those anxious kids who are particularly like somatically preoccupied, sometimes that can be uncomfortable for them. So I think starting then with just like some education of like, check their heart rate, it's not, it's in the normal range that it's okay. And sometimes they learn to tolerate it, or sometimes they continue really not like how that feels. So then you can switch to something else. I think in terms of when you treat anxiety first, it goes back to really that, like what's causing the most problems for them. So if there's very clearly issues with anxiety that are getting in the way of things for them, and, it's more a question of either they have a history of ADHD, but that seems to be the less pressing issue right now, or maybe there's some attention problems, but it's less clear. That's kind of when I tend to start with the anxiety treatment first. I think it's also a great question to kind of bring back to the family and the family and kid of like, what are you wanting to try to address first?
Mm-hmm. And there were some questions about like the pros and cons of the different stimulants, methylphenidates versus amphetamines, or Focalin versus Concerta. Could you just give us a couple quick pointers there?
So kind of I think at a global level, kind of overall, the methylphenidates and amphetamines are more similar than different. They kind of on average have similar efficacy and also similar side effects. That being said, we do know that different individuals tend to sometimes do better with one or the other. So generally, if there's a family member who's done well with a stimulant, particular stimulant, I'll often start with that one or at least one in that same class. If not, I'll tend to start mostly with a long-acting methylphenidate stimulant. If they do well with that, great. If there's either issues with lack of benefit or issues with side effects, then I'll switch and try an amphetamine stimulant. In terms of Focalin and Concerta, I think they're both good options. Concerta is definitely one that's probably the one I start the most commonly first, just because it has a pretty smooth dosing curve over time, and it tends to last around 10 to 12 hours, which covers the school day plus homework. And then the disadvantage, though, of Concerta is it has to be swallowed whole. So Focalin XR is a good option. It's a capsule, so it can be swallowed, but can also be opened and sprinkled. So it can be a good option in those that can't swallow pills.
Fantastic, thank you. There are some concerns about long-term side effects of stimulant use, for example, on dementia, Parkinson's, et cetera. What do we know about long-term side effects of stimulants?
Yeah, so overall, I think there aren't significant concerns about that at this point. I think in terms of long-term side effects, the one we have the most evidence for is some potential growth suppression, so that they're kind of at risk of potentially being maybe about 2 centimeters shorter than if they were never treated with stimulants.
Two people asked about long-term melatonin. Is there a problem with that?
I'd say we don't know. I wish we knew. I think there hasn't been anything to suggest that there are significant concerns with long-term melatonin, and at the same time, we know we don't have great data that there aren't concerns either.
Okay, we are just about at time here. I know that there was another question that popped about Endeavor RX. Lauren Hack, did you have something to say about that?
I'll just say we have some emerging evidence for alternative treatments that might be beneficial, like mindfulness meditation, yoga, these video game treatments or cognitive treatments, biofeedback, but we don't yet have enough evidence that these are standalone effective treatments. So you're always going to want to recommend behavior therapy, medication, or a combination, because that's what we have the most evidence for working for the most people.
Fantastic. And for those who can stay on for 30 seconds longer, college kids and stimulants, would you do it?
Yeah, so I would say, it obviously depends on this particular situation. I think you want to have a clear, convincing diagnosis of ADHD. And in that case, I see there's no issues with it. I do recommend with my kids that I'm treating with stimulants going off to college, I do talk to them about concerns about diversion and that, especially, in their dorm room, that to have it in a safe, ideally locked place, because, even if they're super careful with it, their roommate might invite people over that they don't know. And if it's out in the open, that can be a problem for them. So just making sure they know when to never share their stimulant with anyone else, even if that person also has ADHD, that can get them kicked out of school. It's illegal. That's just not something to mess with. And to, have like a little medication safe or something that they take to school with them so that the pills are kept securely and someone can't stumble across them.
And we are over time, but for the sake of the recording, for those who can stay on, I think this is an important question. When do you think about titrating off the medicine, and how?
So it's a great question. I'm gonna, I guess, probably talk mostly about stimulants. I think, definitely, obviously, if there's issues with side effects that come up, that's always a time to think about decreasing the dose or titrating off. If they're have been doing really well with it, and the question is more like, are they still needing this? It can be helpful about once a year to do a planned trial off the medication. I recommend doing it during the school year, maybe more in the spring after the teacher knows them pretty well. But not during a time where they're doing standardized testing or midterms, not during a high stakes academic time. And then you can get rating scales from kids, parents, teachers, both on the medication and then off the medication, and still see if you're still seeing that benefit. Often, just the nature of ADHD kids, they miss their meds sometimes. So often, even without a formal trial off, parents and kids can say actually, I forgot it last week and I was still doing fine in school, or, oh boy, they forgot it last week and the teacher was calling, it was a mess. So often you can also get information that way about whether it might be worth to try off.
Fantastic. This is great. I will stop things here. Thank you so much, Lauren and Lauren, for this fantastic talk. We will be posting the recording online on our website. So look for that coming within the next week or so. And I'll be looking to email the PDF of the slides later to those who attended. Thanks and have a wonderful day.